who have been the other partner. So alongside the GLA and ADPH, Greater Manchester Combined Authority. So I'm going to hand over to Janelle and then to my other sponsor colleague, Appreciative. So Janelle first.
Thanks, everyone. And I think I'm here also in capacity as chair of the Greater Manchester Directors of Public Health. And hello to, I can see various faces of people I know from different places. So I just wanted to say something very briefly. And before I do, apologies, I am going to have to duck out. I'm on a board budget meeting, as I'm sure a lot of you can appreciate, the difficulty of that a lot of our councils are facing financially, as well as our local populations, both and. So I think what I just wanted to say was we do know how COVID has shone a light on the health inequalities, and the health inequalities in our population. But I think there's a broader and deeper understanding amongst people. So we also know that the epidemic has exacerbated those particular inequalities, perhaps created others. And we know that in a crisis generally, but certainly as big as this, it's the most vulnerable who are most impacted upon. And I guess also, I suppose there's questions about, well, how resilient is our population generally? There's been debates about health and wealth and the interplay between them. There's also been questions about, well, what kinds of economies do we have that might be vulnerable, or where some people are more vulnerable because they're in those particular economies. Like, for instance, if our economy is based primarily on hospitality industry, what does that mean both for wealth and resilience, but health and resilience of our populations, of our workers, of the health consequences of that economy? I think there's quite a lot there that cities do actually need to grapple with. And I think COVID has brought that to the fore and perhaps disrupted ways of thinking that we need to actually grapple with. And I think what's exciting about this particular project is that how do we grapple with that as cities? Because what is your city based on? The economy, what is the health interplay, and where do our populations sit within that, and what can we learn from each other, challenge each other, and so on. In Greater Manchester specifically, we've just had, as I'm sure you're aware, the Marmot Greater Manchester report, and then we've also had an Inequalities Commission report, and then our Mayor Andy Burnham re-elected with a new manifesto. So there's a number of things there which is great, but also a challenge to. There's a lot of things there. How do we prioritise what to focus on, what to focus our effort on? And how do we do that? I suppose one or two other things. One of the other things about the COVID experience that we're still living through is how multidisciplinary it's been. Colleagues on this call who traditionally I wouldn't have talked to as much, been talking to them, got relationships. What can we've developed different understandings, trust. How can we build on the multidisciplinary nature of what we've been challenged to do? And again, how is that working differently in the different cities, and how can we learn from each other on that? So the last thing, I suppose, is just that spirit of learning, which I think we've had to do at speed in our localities, for us, amongst our localities and at a Greater Manchester level, certainly at a national level. And, how can we capture some of that urgency to tackle the inequalities around COVID? How can we capture that urgency to do that as cities with other agendas around recovery from COVID, the vulnerabilities of our populations, our economies, and how can we really do this better? But the key thing, I think, is learning from that. And I suppose the one last thing I'll leave with Vicky is just more recently this whole the mayors coming together, or quite a few, around face coverings, and just something about saying, no, hold on, this is really important, and in some ways giving that political narrative and leadership that we really need at this time. So how can we build on that profile that has been created of our political leaders, but also perhaps of directors of public health and others in the system in terms of how we are tackling inequalities.
Yeah, really, really helpful setting the context. So we heard there real live reflection of also how this is feeling in the regions, the voice of the mayor and the power of that. These are strong, vary in their executive powers, but strong, leadership voices for their populations, which I think we've worked with a lot in terms of the COVID response. And then reflecting on the sort of learning elements, local government has a very strong tradition around, evolved tradition around sector-led improvement. And we've maybe had less space to think about that kind of sector-led improvement approach between the regions. So I think I'm also treating this a bit of that start of that journey. Well, actually, what does that look like for us at the regional level? Very well tested sort of methodology at the local government level, but we've maybe had less opportunity to think about that at the regional level. So now I'd like to introduce my other sponsor colleague, Mubashir Jaz, from West Midlands Combined Authority. I think you're going to say a little bit from the West Midlands perspective around getting involved in this project.
Yes, thank you. Thank you, Vicky, for that introduction, and thank you, Janelle, for the context as well. Similar to, I suppose, other areas, and COVID had a huge role to play in how we shaped our response, and we published some, a similar report to what national reports had done around the health of the region, and found, well, not found, but I suppose highlighted health inequalities that have been, persisting for years, and how they had been exacerbated by the pandemic. And what it did was, I suppose, it brought to limelight for the mayor and for the region, what it is that the combined authority could potentially do to address health inequalities. So we were unique in well, not necessarily unique, but different in the sense to Greater Manchester that we don't have devolved powers on health. But as this project has shown, that there's many opportunities that can be availed even outside of that. And I think that's where this project really came in and helped. And has helped, and it's continuing to help, is allowing us to shape that narrative in understanding how we play a role in this region on addressing health inequalities, which traditionally were not on the mayor's agenda, and were, something that were potentially not even, actually, they were not even mentioned by the rival candidate, and the incumbent mayor won, but had mentioned in his manifesto. And how do we play that with the directors of public health in the region? And I think we are building a really good story in our partnership, working with them, and finding the pockets where we can actually add value in this space. And I think that is the real kind of direction that it's allowed us to go into, and working with partners in the health and care system to work with them and identify synergies with them, and actually bring together everyone in the region and really play that role of a regional convener, what a combined authority can potentially do. So in that way, this project has really been quite valuable for us, and I suppose later I can go into a bit more in detail in terms of how specifically it's helped. But in terms of setting the context from a West Midlands point of view, I think we've been quite grateful to be involved in this and learning from our partners in GLA and GM, and then hoping that our unique situation is then able to help other combined authorities and regions going forward.
So the three sponsors, as you've heard, working with the Health Foundation, working with ADPH, creating this learning environment, how do we work together? Let's just pause very briefly. The starting point for these mayors was devolution, and that's very much locally led. What powers did people want locally? So we have a varied picture of those devolved powers. And the first item on our agenda, Phil Swan is with us here today from Shared Intelligence, and Charlotte, who did a great piece of work for us looking at that kind of spread of powers. We're going to have a look at that, some time to sort of look at that and discuss that. We also know that the national debate is now framed very much around levelling up as well. So we might want to bear that in mind as we're kind of looking at this picture of powers, etc. We're then going to move on to, in the later part of the session, some reflection from the policy team, which has been put together and has been working very effectively to support the sponsors and the wider set of devolved regions around some of their reflections and how the work's been taken forward. And then later on in the agenda, we're hoping we'll have a chance just to touch base with our funders on this project, the Health Foundation, and how this connects across to some of the work that I'm sure a number of you have been using and maybe working with and collaborating on around health as an asset, how we frame work around health and some of the priorities for the Health Foundation going forward. So if we bring it back right now to, I'm going to hand over to Phil now, thinking about us as a set of regions. We've grown since we've started this project. There's a set of work that we've done around powers and responsibilities, and thinking how we're going to use this work to support our work and collaboration going forward. So Phil, handing over to you now.
Thank you very much. I hope my screen sharing has worked.
Works, but it's not on full slide mode yet.
Okay,
so maybe if you can put the slideshow.
There we are. Right, thank you. My name is Phil Swan from Shared Intelligence. I'm going to briefly present the results of the work that we did for this project. There'll then be an opportunity for people, if they want to ask questions on the conclusions we reached, and also hopefully there'll be time for, in discussion, you to add to the story and say a bit about what's happened since in this space. We were asked to map the action being taken by the GLA and the then 8 mayoral combined authorities to address health inequalities. And I just want to stress the fact that we finished our research in January, February 2020, and we finished our report in May, June 2020. So this is all pre-COVID. So please think about our findings in that context. This is the world before COVID. These are the list of the mayoral combined authorities we worked with, plus the GLA. Worth noting, there's now one more mayoral combined authority with the first mayoral election for a metro mayor in West Yorkshire, which happened in May this year. As Mubashir said in talking about the West Midlands, he used the word unique, and I think one thing to stress right at the start of this presentation is that the combined authorities and the GLA are very different, and there are also significant differences between the combined authorities themselves. The legislative basis differs, the scope and nature of the devolved powers differs. A GLA established in 2000, first a combined authority established 2010, most recent a combined authority established 2019. So there's a journey here. There are significant differences in the size, scale and geographical complexity of the combined authorities, and it's also worth noting that the transfer of public health to local government happened 13 years after the GLA was created, but before the first mayoral elections in any of the mayoral combined authorities. We've done some further work on combined authorities in a different context since this work was finished, and I think I'd also stress that there are differences between the combined authorities in relation to how they work with and relate to their constituent councils, and also in terms of the focus of the combined authorities, with some of them forensically focused on one or two issues and others addressing a far more wide-ranging agenda. Stress that this next slide was drawn up a year and a half ago. At that point, there was definitely a spectrum of activity in terms of the extent to which the GLA and combined authorities were devoting attention to health inequalities, with the GLA at the significant amount of attention end of the spectrum, and some of the other combined authorities are paying less attention to it. Greater Manchester paying a significant amount of attention, and then West Midlands and Liverpool city region. The things that we think lay behind that spectrum of attention are summarised on this slide, and I'm going to say a bit about each of those headings in my short presentation. History matters. So, as I said, a GLA established 1999, given responsibility for health inequalities 2007. But the combined authorities are more recent, but there's a spectrum. They're established over a period of time, not all at once. And in many of those areas, the establishment of the combined authority followed a long period of collaboration between the authorities across the combined authority geography. Geography matters. In some cases, for example, the GLA and Greater Manchester, there is a high degree of coterminosity. In the case of some other combined authorities, there is far less coterminosity with, for example, health boundaries not following the same boundaries as a combined authority. The nature of the relationship with Public Health England differs across the combined authorities. And as I said a few minutes ago, the nature of the relationship between the combined authorities and their constituent councils and directors of public health also varies. As I think all the speakers so far have said, mayors matter, and the extent to which a mayor is or is not interested in health inequalities is significant in terms of the amount of attention the combined authority devotes to it. And as I think that Bashir said, the fact that a combined authority does not necessarily have a statutory duty in relation to health inequalities does not mean it's not taken seriously. Mayors can use their convening role in this area. Mayors can influence the priorities of the combined authority, and increasingly mayors are acting as a spokesperson on behalf of the areas they represent, and we've seen that over the last 18 months or so. And then, as I've said a couple of times, there's quite an important relationship between the combined authority, Public Health England, and the directors of public health. And also we notice that the extent to which individual council leaders and chief executives take an interest in this subject or not also has an impact on where it sits on the combined authorities agenda. We found that there were four things that drove a combined authority interest in health inequalities. In many cases, it was because poor health was seen as a barrier to work and productivity, and therefore, from an economic point of view, important for a combined authority to take seriously. Other combined authorities looked at health inequalities through an inclusive growth and public service reform lens, and then, particularly in the case of Greater Manchester, looking at population health and health inequalities in the light of their devolved responsibility for health and social care. In terms of what combined authorities and the GLA do, we identified four sorts of activity: developing and adopting strategies, convening partners and stakeholders, pursuing specific initiatives, and taking health considerations into account in exercising their other powers, which is a theme of this slide. So I think even though, as we've said, not many combined authorities have specific responsibility for health inequalities, but they do have responsibility for many of the wider determinants of health, particularly transport, the economy, and housing. Our combined authorities also bring geography and scale, and in a number of cases they also bring some additional capacity to explore this area. Final slide, some reflections. What matters in relation to combined authorities' role and action on health inequalities? The remit, mandate, power, and I think I'd add interests of the Mayor. The value of strategies as a foundation for action on health inequalities and a kind of calling card to convene other partners to collaborate. The importance of the relationship with Public Health England, as was when we were doing this research. In Greater Manchester, the importance of their devolved powers around health and care and the role of the health and care partnership. The significance of the drivers of action I mentioned a minute ago, and the links between combined authorities' interest on health inequalities and their increasing focus on the climate emergency, and the fact that many of the issues relevant to addressing the wider determinants of health are also relevant to addressing climate change, the most obvious example of which is transport. And the final slide is something we captured from Liverpool, and I thought I'd use it because I like it. So I'm going to unshare my screen, I hope.
Thank you, Phil. So we've got about 15 minutes now. So I suppose first question, I need for clarification for Phil. And then I think we're going to get into a bit of conversation around how this has moved on or potentially changed. So reflecting as Phil has, developing this picture took a while and some quite detailed conversations. As we say, kind of really that culminated just as we were about going into the pandemic. So I suppose it was a chance now to reflect on, what has changed, what has moved on. So I suppose there's two quick reflections I'd kick off with just from a personal perspective. The relationship with council leaders in the region, between the council region and elected mayors, I would say has totally transformed in the context of COVID, of having such an acute shared agenda about your population, and that in a way broadened out a little bit more even to include a relationship with another set of politicians, the MPs. So within our region, and I'd be interesting, the political mandate that various elected politicians have when you've got something as big and as acute as the pandemic, did kind of allow people a sense of regrouping. Oh, well, hang on a minute, what are our political mandates? Because actually, what we can't afford to do is be crisscrossing across populations. So that was one reflection. And then I guess the other is the NHS's focus and interest on health inequalities, which it's not that it wasn't there previously, but their role as an anchor institution as part of recovery, having been through a very intense period of work between the NHS and local government around the response in a place, again, to the pandemic, also feels like it's moved on sort of significantly. So a couple of reflections from me there around different politicians and how they work together post-COVID, as well as NHS's focus on health inequality. So if we open it up now, Phil, how do you want to do this? Do you want to take the questions as they come through, or do you want me to change them? You take them. Brilliant.
I think Sue Gibbon has said that she'd like to make a contribution by raising her virtual hand, and if others would like to contribute, if you could do the same thing, just either use chat or the hand function. Sue.
So good afternoon, Phil, and thank you so much for sharing that with us. I'm going to be a little bit parochial, if you don't mind. For those of you who don't know me, I'm West Midlands PHE Director. So you've mentioned a number of times the importance of the relationship with PHE, and I just wondered if you could say a bit more about what was important, what was the value that you thought, that you understood PHE was providing. And the second part to my question is, so does that carry any implications for the ongoing support that may or may not be needed from the regional system as PHE disappears and as the regional public health function moves into the Department of Health and Social Care and the NHS?
Thank you. I guess we captured that as a feature because I think in our conversations, two things struck us. One is captured actually in the way Vicky described her unique role in London, with a foot in Public Health England and a foot in the GLA. So a real organisational link between the two, which I think you can see, which does lead to, it helps to explain the strength and depth of the focus on health inequalities and health in all policies within the GLA. And then in Greater Manchester, I think a number of people we interviewed there spoke about, I think I used this phrase on the slide, a three-legged stool with the combined authority and the Health and Care Partnership as one leg, the Regional Director of Public Health England, and I think it was a he, and his colleague as a second leg, and the Directors of Public Health as the third leg. And we didn't hear any other places talking about the system in that kind of way. And I think that provides a platform for a collaboration of a type that I think is really important. I forgot the second half of your question, sorry. You're on mute.
So what are the implications of that as PHE disappears, I suppose? That
the successor organisation should see the potential strength of a strong relationship with combined authorities, and through the combined authorities, a collective relationship with the directors of public health, council leaders and chief execs in the area. Greg, you've got your hand up.
Cheers, Phil. So Greg Fell, Director of Public Health in Sheffield. Sort of an observation more than a question, and I welcome your views on it. On the point of language and ownership, it's got the word health in the title, therefore the NHS thinks it will own it. So there is the who leads. So clearly the NHS deals with the consequences of it, but not just the NHS, because you've made the point about economic productivity, social justice and all of those other things. And then leverage over the policy tools and powers and the convening power of mayoral combined authorities have got. I'm not convinced that the NHS has moved on, to be honest. I don't think it's right and reasonable to expect the NHS to be responsible for, say, housing policy or economic strategy, because that's a world beyond the NHS's usual comfort zone. But I do think it's right that the NHS makes a full contribution to its part of housing policy or economic strategy, and we find the sweet spot both in terms of strategy and in operational delivery, where those staff that have got the word housing in their job title and those staff that have got the word NHS in their job title, and social care, let's not forget social care, all find a way to collaborate operationally. And I think we're a good way from that, actually. Just an observation. I'd welcome any thoughts you've got on it.
Well, I think it's a really important point, and as you know, we interviewed you a couple of weeks ago for a different piece of work we're doing on
I'd forgotten, yes.
on health in all policies, and I think if we were doing this research now, we'd probably have at least one other line of inquiry, which is the extent to which the combined authorities' statutory responsibilities in relation to transport, the economy and housing drives an interest in health and health inequalities, and whether we can get a genuinely joined up approach to climate change, inclusive growth and health inequalities that doesn't come with a huge strapline health in the first word of the first headline. And I think that and the mix of responsibilities that combined authorities has plays straight into that I think.
Yeah.
And is a really important thread for me. I think a woman called Grace said something in the chat which seemed to be relevant to this. Do you want to speak to it, Grace?
Sure, absolutely. Thanks, Phil. And absolutely relate with the points that Sue was raising, that this has been a challenge identified not only in the West Midlands, but other sponsor regions that we've been working with here, with how we as combined authorities build our relationship with what will be the new PHE structures, and the value that working with PHE brings. And that's going to come out in my analysis presentation later on. But actually it is holding a lot of the evidence and the knowledge around how we address health inequalities. So really that relationship is actually integral to combined authorities working in this space. So yeah, I agree with your point, Sue.
Thank you. Lola, do you want to speak to the point you just made in the chat?
Thank you very much. I'm really just sort of supporting the point that Sue's made. I do think that as we go forward into the new regional arrangements, that we should be seeking much stronger relationships between whatever the new regional functions are and the combined authority. I think that, working with our DPH colleagues, we have been able to fire in a whole host of resources, ways of working, and we connect up the system. And I think that that is making a difference in terms of some of the initiatives that have been put in place. And the narrative of health and wealth is one that has been taken up quite consistently across all of our organizations. The language may vary, but the intention behind and what we're trying to achieve, they're great commonalities.
Before we close this session down, I wonder whether anybody has got anything to say about the personal contribution that mayors have made to this agenda, because it seems to me that their profile locally and nationally is probably higher now than it was 18 months ago. When we were finishing this work, it was clear that the extent to which the mayors were interested in this subject had a direct impact on the extent to which it was being taken seriously at a combined authority level. Any reflections on the role of mayors in this space now, after what we've after the last 18 months or so?
Plenty of them have been fairly visible since, and again, most obviously the face mask gate of a week or so ago. I think there's a really interesting opportunity going forward to capitalise on they've always had this interest, and now they have thrust themselves into the spotlight. We've never really capitalised on their collective political leadership and convening power, I don't think. But I'm not close enough to it to know that for a fact. But I think there's all sorts of interesting opportunities in that space.
Yeah, thank you, Greg. I'm Bashir, and then I'm going to go to Vicky, both to her point and to close this this part of the session.
Yeah, no, so I agree. I think that role is getting defined as we speak, and the pandemic has probably has sped that up, and certainly and kind of mobilizing interest and getting everybody together around the vaccine rollout, and kind of even though it's the local partners and the directors of public health who are leading the work, it does help having playing that role around a regional convener, and I think the vaccine rollout was one thing, and certainly the kind of leadership shown and the unity shown by the mayors in the mask agenda is also another good example. Going forward, do they play that role? I think what is the value that they can add? I think this project has highlighted opportunities, and I think Grace and Alice are going to go into that in pretty soon. And there's plenty of takeaways for us from this. And the good thing that we have now is we have the mayor's ear, and we have we can shape their role going forward, and we've already built up those great relationships with PHE and the directors of public health, and now it's time to actually define what role it is the mayor can play.
Great. Well, thank you very much. Thank you for listening. We really enjoyed doing this piece of work, and we look forward to seeing what happens next. Vicky, back to you. You're on mute, Vicky.
Big thank you for the piece of work and for revisiting it 1 year on and bringing it to life, which has been very, very helpful. I'd agree on the point about vaccination being something that the mayors are collaborating on actively and regularly so that we can build on. I think we've also got a live experiment, really, having gone through the pandemic. London, the mayor has no responsibilities whatsoever around health and social care, and is sort of legally excluded from doing anything in terms of commissioning of health and social care. We've got other models, very different in Manchester, for example, with their devolution model. So there's a lot to learn from around how stuff has got done in the context of quite different powers that I think in terms of the learning network we can build on. So we're going to move on now to, I think, which is going to really build on the conversation we've had so far around how are the powers and responsibilities set out, how organisations frame this, kind of what were they doing pre-COVID, what do we feel has changed, to hear from our policy team now on the work they've been doing to drill down a bit on how that is working, and a very live kind of assessment, if you like, of that. So I'm going to hand over to Alice and colleagues to take us through this bit. And Mubashir, I think you were going to lead us through this session. Thank you.
Thank you. Yes, I think, without further ado, I think I've already stated the impact and the importance of this work for us, and I think it's important that we share these findings and then have some discussions that follow on, but more importantly then talk about what the next steps would be from this. So I'll bring in Alice, who's been leading the policy team, and Grace, who's from the West Midlands side, and our team here. So take it away, guys.
Thanks, Mubashir. Can I just check that everyone can see the presentation in big on their screens?
Yeah, we can.
Great, thanks. So as Mubashir said, Grace and I will be going through our findings so far. So I'll just go on to the next slide, which has the plan for this session. So as Vicky described, the policy team started in April, and since then we've been based in GLA, West Midlands and Greater Manchester, and we're going to use this part of the session to describe our work to date. So starting off with an overview of some of the differences between our regions. Then we'll talk about the Appreciative inquiry framework we've developed, and that's a tool that's designed to support reflection and collective learning at regional level, despite the differences between our organisational contexts and ways of working, as Phil's already described. And then we'll summarise some of the shared challenges we've identified through our work so far, and how these might be the starting point for further learning going forward. So the aim of this project is to really be flexible and responsive to your needs. So the most important part of the session, I think, is to hear about how we can support your work on inequalities, and we'd be really grateful for any reflections and feedback from your regions. So on that note, we've included a voting option in one of the slides, so that's using Mentimeter. So Grace will put the details of that in the chat. It's just one question, but it'd be great to hear your views. So I'll hand over to Grace now to describe the context and the regions we've been working in so far, and how that influenced the way in which we undertook our research.
Great. Thanks, Alice. And yeah, I've put those Menti details in the chat. So as you'll be able to see from this slide, and it's already been alluded to several times today, each sponsor region has its own extremely unique context around devolution, its strategic approach to addressing health inequalities, and COVID recovery. So what we've attempted to do is to understand these differences and then design our approach to account for them. And we found the shared intelligence report that Phil presented earlier really helpful as a framework to approach our thinking. So if we look at the first column here, devolution, context and mandate, we can see that Some areas, i.e. Greater Manchester, has full health devolution in comparison to other areas that have a health inequalities strategy. Some areas, for example, London, this is a statutory duty. Other areas, it's not a statutory duty, so there's no mandated need to have a health inequality strategy, but this has still been progressed. West Midlands has one. I know that other areas also have one. And then if we move on to the next column, taking a look at the strategic context to approaching health inequalities, in some cases, cost-effective analyses to galvanise on transformational opportunities that are afforded by devolution deals may be an approach taken forward. This was adopted in Greater Manchester, or perhaps utilising mayoral and governance structures as convening mechanisms. This has already been alluded to as a technique used in West Midlands, or perhaps focusing on capitalising on devolved powers around the wider determinants of health, such as the approach taken forward in Greater London. And then moving on to the context of COVID and its recovery and how that has really changed the health inequalities landscape for every region. So as Janelle mentioned earlier, this may have led to the commissioning of Marmot and his team to produce a regional Build Back Fairer report to focus the system on an equitable recovery. Or perhaps using COVID as a leverage into the healthcare system, where the combined authority may have no official permission to act in this space, such as what the West Midlands Combined Authority have done. Or progressing action through a system-wide recovery programme, such as that taken forward in Greater London. So with keeping these differences in regional approaches in mind, let's now take a look at the different opportunities for learning that this project has enabled. So there's been a great deal of focus on understanding how best devolved powers can be used. And this has been a real big focus area for London and West Midlands. There's also been appetite across all three sponsor regions, and we're hoping the wider 7 as well, for being part of the community of practice for understanding city regions' approaches to acting on health inequalities. And then also the value and understanding, and again this was alluded to earlier, approaches on how do we prioritise around this busy agenda. And this has been a focus area for Greater Manchester. So I'm now going to hand back to Alice to take us through the appreciative inquiry approach that we took to this piece of research.
So the way we worked was through looking at case studies on health inequalities work in each of our regions. So through examining these case studies, we were able to extrapolate some key themes for regional health inequalities work. We then used those themes to develop a set of questions that would help us draw out organisational learning on health inequality. So that's this framework we're about to present. So given the differences in regional contexts, the idea was that these questions would be more generalisable to a variety of regional contexts, rather than a set of recommendations which would either be too vague or too context specific to be useful. So I'll go through and describe that now. So we came up with 3 sets of questions. The first set was around identifying needs and prioritising action. Second was around identifying and using levers for change. And third was around thinking about the value add, so how work at combined authority level can complement health inequalities work being undertaken in the rest of the system. So the idea is that people working at combined authority level could use these set of questions to draw out and reflect on opportunities for learning in their own regions, and also identify where we can learn from each other. So we'll circulate the full set of questions afterwards, but in the next slides, Grace and I will present some of the reflections and opportunities for shared learning that came out of the appreciative inquiry process in GLA, West Mids and GM. We're leaving lots of time for discussion and reflection at the end, so it'd be great to hear whether these questions trigger any reflections or thoughts in relation to work in your regions, or how we might build on this appreciative inquiry approach to support your work. So I'll go through and describe the first set, which is around identifying needs and prioritising action. So in the first column, thinking about the role of the combined authority within the system. So building on some of the factors that Phil described, the relationship with localities, the relationship with PHE in the context of restructure, the role of the combined authority within ICS development, for example. So the key questions here around the mandate and the role of the combined authority. What do we want to prioritise? And if we aren't best placed to take action on a particular priority issue, then how are we working with partners across the system to support them to take action? So this means exploring how we engage internally across directorates in our own combined authorities and partners, but also how we engage with external partners, how we're responsive to gaps in the rest of the system. So next, in the second column, we thought about entry points. So first, what's the strategic capacity within our organisations to horizon scan or to respond to new needs or new opportunities? And linked to that, how are we working across directorates to capitalise on opportunities to influence health through our wider determinants and the powers we have in relation to them? And finally, how are we thinking about our approaches to prioritisation and collaboration? How do we prioritise in a systematic and robust way? So third, we looked at public health intelligence function in our combined authorities and how data and intelligence were used in each of our areas. And we identified several different roles for combined authorities in relation to public health intelligence. So these included things like using data to understand and draw attention to regional needs. And that's really important in the, following the pandemic and the new and different inequalities that we're seeing. Secondly was around using data and evidence to prioritise. Thirdly was around driving action across the system, around measuring impact of combined authority-led programmes, and a final role was around visibility and accountability for regional health inequalities. So really, the use of understanding these different roles helps us think more clearly about how we might design our data functions and also how to choose relevant indicators which facilitate different roles or different agendas. So, for example, the box that just popped up about West Midlands, having the public health function embedded in the inclusive growth unit meant that it fed into strategic prioritisation of the work of that unit. So it had a strategic as well as reactive public health intelligence function. Moving on to another example, we saw how in Greater Manchester the choice of indicators helped drive work across the system. So the early years work was supported or measured by impact on school readiness, and that was an indicator that spoke not only to health but also to social care and education sectors. And the other really important thing about this indicator was there's a big gap between the regional and the England average, and that was a really important motivator and driver for whole system action. So the next set of questions I'll talk about are levers for change. So first, we looked at leadership at combined authority level. So we've touched on this already, the importance of understanding where the drivers and the mandate for action on health inequalities come from. Picking up the point from Greg earlier about the value of collective political leadership from the mayoral group, how do we capitalise on the potential of this? Are there examples where leadership opportunities have been taken up in the absence of devolved powers? And if so, what were the reasons behind this or the facilitators? We also tried to clarify what we might mean by mayoral leadership. So is it convening local leaders, activating cross-sectoral networks, holding the system to account, upwards advocacy, shaping public debate, and what are the kinds of challenges in balancing multiple roles in different policy areas? And also thinking about, really importantly, the impact of the public health pandemic and how this might have affected how mayors are engaging with health and health inequalities, and picking up on the point that Janelle made about recent conversations about face coverings and powers over transport systems, for example. So next we thought about financial resources. Firstly, thinking about how investment at regional level might shift the balance between prevention and service delivery. So a really good example of this, I'll just pop it up, is one from Greater Manchester, where invest to save models were a really big part of the design of the population health plan. And clearly this is an example from a region which has devolved powers and budgetary responsibility for health, but there may be ways that other areas could learn from this approach in relation to using our non-health responsibilities and maximising their potential to support the prevention agenda, for example. Next, we looked at how combined authority action can support the pooling of resources across sectors. And we also looked at examples of where resources have been leveraged for system-wide work. So an example for this was in West Midlands, where national funding was used to pilot and demonstrate the impact of innovative work between sectors. For example, this is around work and health. So lastly, trying to better understand how combined authorities can use their wider functions or regulatory powers to address health inequality. So an example of this came from GLA, where there's a big focus on health and health policies and how to embed that more systematically across the GLA and the GLA group. Thinking about what are the mechanisms that have been used to address inequalities through wider functions. So is it through influencing policy? Is it through piloting cross-sectoral programs or deploying regulatory powers, for example? And what were the facilitators for each of these? For example, one of the case studies we looked at came from London. We looked at the junk food advertising ban on the London Transport TfL network, and how in that case having a system-wide childhood obesity strategy helped build momentum and also political appetite to deploy that regulatory power, for example. So as new powers have been granted, has that shifted the focus from prevention to service delivery? How does devolution of more powers affect prioritisation, for example? And lastly, how have data and evidence been used to guide action and to demonstrate impact on addressing the wider determinants at combined authority level? So what's the kind of size of the prize for action at regional level? So now I'll hand back to Grace to talk about the third set of questions, exploring value add of a regional approach.
Great. Thanks, Alice. So the value add of the combined authority regional approach, I'm sure other people can relate. This is a question that comes up time and time again. So really the key question that we asked ourselves here is, what is the offer of the combined authority to the rest of the system? So how does the combined authority use mechanisms at its disposal to add value to work ongoing in the system around health inequalities? So if we take a look at the first column here, we found it helpful to look at how combined authorities support collaboration and partnership across sectors and across agencies. So we ask questions around who is engaged and how. Is it the ICS? Is it voluntary community partners? Is it Public Health England colleagues? And then how does that regional approach challenge system bottlenecks or system silos? And then what were the facilitators, leadership, structural enablers, such as powers and resources that led to that partnership work, i.e. perhaps driven forward by the mayor and senior leaders across the system on the opportunity to collaborate around a common agenda? So, for example, system blockages were removed by the emergency that COVID placed on housing and health, which allowed for rapid collaboration and action across the system to house those sleeping rough in the Greater London Authority area. Moving on to the second column here, we also explored how combined authorities were ensuring that they were adding value to ongoing work in their localities. So this might be by way of technical support, i.e. around data intelligence, best practice. It may be facilitating opportunity for innovative programmes or ways of working, or perhaps structural enabling afforded by working economy of scale. So, for example, working collaboratively across localities on investment cases for system work to take action in a do-it-once approach added value to the school readiness agenda in Greater Manchester, where multiple sources of data were gathered and integrated to develop a cross-system view of an issue. And then finally, moving on to our last and final line of inquiry, we explored the value add of a combined authority regional approach to engaging residents and building the public mandate for action on health inequalities. So here we looked at the value and context for when engagement approaches were prioritised in combined authorities. For example, this might be using participatory processes through which citizens frame the combined authority's priorities, or embedding citizen voice within quantitative measures for a more nuanced understanding of what good looks like in a local place. Or perhaps supporting other parts of the system, this may be the new ICS structures, with an approach to community decision making to avoid what often can be tokenism engagement. Approaches such as these have been prioritised within the West Midlands Combined Authority. So I'm now going to hand back to Alice to speak to the shared challenges that started to emerge as we went through our appreciative inquiry process.
Thanks, Grace. So we've alluded to lots of these already. So just to kind of orient everyone, we've tried to kind of provide an analytic framework for how we're trying to draw out learning, bringing some tangible examples from each of our regions. And I think we've touched on most of these challenges in the slides you've just been through. So really around data intelligence, specifically in the wake of the pandemic, building and capitalising on the potential for leadership and building the mandate for that, balancing multiple leadership roles, prioritisation, and making the most of non-health powers, and maybe learning the lessons from combined authorities who have health powers. So in relation to each of these challenges, this is a very busy slide and I apologise for it. This is why we circulated them in advance. But the idea is to think about where are there examples of avenues for mutual learning in relation to each of these challenges. And you can see, I'm not going to go through all of them now, but there's lots of different examples of work in relation to each of these challenges that can really share lessons between authorities. And this is just from our 3 sponsor regions. And I'm sure there's many more from regions more widely. So next, we're going to ask you to vote. And I hope everyone can see the Menti link. So the idea behind this is really, these are the challenges that we've kind of uncovered from the sponsor regions, but how much do these resonate in your region? So do feel free to say other if none of them resonate. We've got space in the chat or space in the discussion afterwards to explore things that we might have missed or that might be relevant in your areas. But while people are voting, I'll just go through some of these to kind of clarify them a bit. They're the same as the ones I presented in the previous slide. So using data to understand health inequalities in the region and also to guide action, being a challenge, the complexities around that, who does it, how. Second, around building the mandate for leadership. Third, around prioritising opportunities and how to do that in a systematic and robust way. Fourth, using non-health powers, embedding health and all policies approaches, how to kind of operationalise those kind of commitments. Next, around balancing competing needs. So one of the things that came up in our regions was around balancing economic recovery and also equitable recovery as being kind of thing that could have some degree of tension in some circumstances. Finally, around community engagement. So approaches and methods to ensuring community voices reflected in work at regional level and other. So do feel free to say, either put up your hand or say in the chat, or we can touch on it in the discussion afterwards. So looks like community engagement is coming up very strongly. Health and on policies as well. Balancing competing needs. It looks like there's kind of broad agreement on all the challenges, some others, so hopefully we can look at them later. Do continue to vote. I'll move on to the next bit, but we can bring back the kind of this slide at the end with the final results. So do continue to rate our challenges. So I'll leave everyone to do that and we'll keep going and talk to the next steps of the project. So I'm going to hand over to Grace for this section.
Yeah, thanks for that. Really, really helpful use of Mentimeter there as well. So thanks everyone for participating with that. So drawing to the end of my analysis presentation here, as a policy team, our purpose for today was to really find out how this project can best support your work on health inequalities. So far, we've facilitated workshops at the sponsor regions. So, for example, we've used the Appreciative inquiry tool to both reflect on, identify gaps and accelerate action. We'd be happy to offer this out to other regions if that would be of benefit. And then as shared challenges started to emerge as we went through our research, we started to facilitate discussions with officers working on these challenges at our sponsors' authorities, and we shared these ways of working with each other. So there's a potential to build on this, on the specific themes that came out of this for future events for the 10 mayoral city regions. For example, this might be around prioritisation or inclusive economic recovery, or we may look to what's come out strongest in the Mentimeter vote that we've just had. And then finally, at the start of this project, we undertook some policy mapping across the 3 sponsor regions. And from this, we've set up an informal mental health policy network. And the purpose of this network is to support each other on challenges faced by those working on mental health at a combined authority level. So there's opportunity for this network to be expanded across other regions working in this space, or to perhaps duplicate a similar type of network in another policy area. So what I'm going to do, I'm now going to hand back to Bashir to speak on the West Midlands experience and what we've benefit or haven't benefit, but I hope we have, from what we've been doing in this project, and then to open up to discussions on what other regions would find helpful from the policy team. So thanks, everyone.
Thank you, Alice, and thank you, Grace. Certainly, I mean, I think for us, the project has been super helpful in, talking about. So we've been lucky, I suppose, in the West Midlands. We've had excellent support throughout from Public Health England and in kind of establishing the role of the combined authority in this space, and this project allowed us to take that further. So things like some of the outputs, the Appreciative inquiry tool, and allowing us to identify the gaps where we could make a difference. Hosting workshops with colleagues within the combined authority, allowing us to influence some of our colleagues where we do have statutory powers, like in transport, like in housing and productivity and skills, and getting them to see the difference that potentially we can make by working in this space and addressing some of the wider determinants of health. The work around the community of practice that's being established is really helpful for us in the work we're doing to establish the Mental Health Commission in the region. My colleague Jed is here, who's leading that work, and I think he jumped on the chance to be able to connect with colleagues across the country and learning from each other and applying those to make sure that we don't continue to duplicate work or actually work in spaces where it might be better for other local teams to be doing some work. So I think all of that has been quite helpful, and certainly I think we're looking forward to the establishment of these communities of practice across the mayoral authorities, the M10 now, and how we can continue to learn from each other. We're going to continue to use the gap analysis and policies that's been done for us as a great tool for us to take forward with our partners in PHE and whichever form they end up taking, and the directors of public health and some of our NHS partners who are also here in this workshop, which is testament to how far and wide we're working in this region. So with that, I would say thank you again for showcasing some of the tools and the products that have come out from your work. And I want to then open it up to discussion and potentially go back to your Mentimeter there, Alice, and see which areas it is that we can discuss further. Do you have an updated poll? You do?
Yeah, the results are in. I'm just going to share the right slide. 1 second.
I'm not sure I can take the suspense.
I know.
Sorry. It's like waiting for Eurovision results to come in. Can everyone see that?
Right. Yes. So I think community engagement is coming out quite strongly, and I think we saw that. And I'll just, this is the last bit I'll say, and then I'll open up to discussion. Is we've seen this in our region in West Midlands when we ran parallel to this work design sprints with our health and care partners to see where it is within this the broad kind of health inequality space where we could make a difference, and community engagement at a regional level and on specific issues and stepping away from talk shops was one area that we identified that we're working on now as looking to do a tangible output in the coming year. So certainly that's good to see that others see benefit in that as well. But I then now can open up to discuss further any questions, any kind of things that we'd like to ask Alice and Grace.
Maybe at the beginning I could have set out a little bit more clearly in terms of the where we are in this project cycle, in terms of what this information is feeding into in terms of the next design of this project. So we have funding for this project for the relative short term. So part of this conversation is about literally what we focus on in the next few months with you as a network, in terms of a wider group beyond the core sponsors. And it's also getting some information that will help to shape actually if we are a community of practice and there is an appetite for collaborating on this, what are some of the issues that we might want to explore in the slightly kind of longer term. So this conversation now is giving us a steer on sort of immediate priorities for the project, as well as the shape and the interest of what a community of practice might look like in the longer term, if that's helpful. Appreciate there was also quite a lot in the presentation, so if people have kind of questions for clarification as well, now would be helpful as well to grab some of this time.
Maybe just building on what Vicky was saying, I think some of the real value of the project is around the kind of discursive element of it. So really the kind of, rather than us pulling out findings or recommendations, I think the things that we found most valuable as a policy team is that kind of back and forth, exploring how things are done differently in different places, and thinking about how hearing perspectives of how others are working really kind of reshape our own thoughts about how we work, or how opportunities that we might have missed, different ways of working that we may not have engaged with already. So I think just to flag that, that kind of the discursive value of this kind of project.
So just before we go to questions, I mean, one more thing to say is I think the Health Foundation is certainly looking to build on this piece of work as well, and help use this as example of tools and enablers of how we can work together in urban city regions. So lots of potential here, not just in the remaining, but in terms of legacy of this work. So if I can bring in Greg and then Sean, who started this work in West Midlands before me. So Greg.
Cheers. Three quick things. Just some quick observations. There's something about landing. This is a going forward thing. Landing where we want to be on this, around the menu of specific policies that we might want to put into place and enact, aka the Marmot Greater Manchester thing, which was just spectacularly good, versus something that transcends that, or is a sort of a step above that, and it's the sort of the shaping thinking, sponsoring new ideas, connecting things together. It's the power to transcend paradigms, which, if you read the Donella Meadows stuff on complex adaptive systems, is by far and away the most important of the leverage points. So there's something about landing that right, in terms of specific versus broad and rather more difficult. Something to think about infrastructure to enable some of this. This is a room full of a lot of public health professionals, where we all think in a certain way and probably act in a certain way. Is that right? Is that enough? And if you have a room meeting on climate, a room full of climate professionals that won't talk to anybody else. There's something about this constituency talking to other constituencies, and just something to reflect on capacity. If there are multiple levels of geography at play here, there's clearly a place-based geography, there's a city, region or mayoral combined authority, and there's other levels of geography. If we have to divvy up our capacity, which is a very real thing for most directors of public health, where do we put it? And I think it needs a bit of thought. So 3 brief observations on probably medium term rather than immediate.
Thank you, Greg. Sean.
Thank you, Mubashir. And I was going to pick up on the points that Greg actually raised. I think it's about actually getting at people in the room who are not necessarily using the lens that we're using, which I think is very, very important. And I know you've done a lot of that through the work we did with the Health Inequalities work in the West Midlands. It'd be lovely to see that replicated more broadly. The second bit for me, it's also about people with lived experience. So again, getting a sense of on the ground, how do we bring people into our conversations who are living and experiencing that every day of the week in their locality? And there's some real strength in that, about actually how we drive that forward. And then actually what we're doing then, we're creating a top-down, bottom-up mix, really, of really thinking about the broader health inequalities. And I know there's lots of work going on in that space, but how do they become engaged in our work? So we feel it, we hear it, we see it with those individuals actually as part of our discussion. And then the other bit, I think don't lose track of the COVID world as you've been describing all the way through the presentation, which has been amazing, that the political power that's brought together. But forgive me for being a cynic for a second. When COVID goes away, if ever, the ability for the mayors to work together in the way that they are working now may not be the same, because there may not be the similar drive that they've had for this ambition. And actually, maybe then there are different actors and issues that need to be resolved to do that. So while we have a common enemy at the moment, forgive my language, but actually everyone will join up to join that position. But when that position changes, actually the influences of our mayoral candidates may change depending on politics, power, a whole host of different issues. So it's just thoughtful about where that sits going forward and how we play that out into this arena too. But I have to say, so far, brilliant piece of work, and well done for taking it forward in the time we've done it in a really difficult space.
Thank you, Sean. So anything on that did you want to come in on that, Grace, Alice, that you learned from your work in terms of, especially the point about lived experience?
Grace, did you want to say something?
Yeah, no, Sean, that's a really vital point, and Mubashir did touch on that as well, and I touched on it earlier, is how do we bring in that lived experience, citizens' voice, community engagement aspect to what we're doing here, and that is a very embryonic project that we're starting in the West Midlands, and really trying to build up a framework of how this can be replicated on a much broader scale and adapted to different organisations' needs. And it's definitely a topic area that keeps coming up time and time again at different types of organisations, different geographical levels, and for different policy areas that impact upon health inequalities. So absolutely with you on that, and I think, as I can tell from the chat, most people on the call are as well, so perhaps that is something for myself and Alice to bring back to this audience. So yeah, thank you for highlighting that.
Yeah, I think the next step for us is really to kind of, as you can tell, this is a very broad piece of work at the moment. We've presented a lot of information in a very short space of time. So I think the next step for us is to kind of assimilate the really helpful comments we've had in the chat and also online, and try and focus down what we want to focus on for the remaining months of the project and think about how we do that. So it's really helpful to hear the comments. Thank you.
Definitely. And I'd also like to, I think that is a really important point around who is in the room when we're having these conversations. And that's definitely something that we've been trying to achieve with the Appreciative inquiry tool. And we trialled this in the West Midlands, was actually using it as a tool and a resource to bring together different directorates to make this everyone's business. Oh, I've just heard myself there. But to bring together different directorates to make this everyone's business, and bringing together key recovery policies within our combined authority and providing that health angle using the Appreciative inquiry tool. So it's definitely something we're trying to tackle with that as well. So yeah, thanks for that point, Greg. I think that was made by yourself and also Sean.
So, sorry, Greatly, I can continue to go on. I think we have some contributions from Matt and Debs. So, Matt?
Thanks. I was just going to pose the question that the Appreciative inquiry looks at the levers and looks at the processes and looks at what's available at a combined authority level. And I just wonder whether the forward look probably challenges maybe some of the assumptions that inequality isn't homogenous between all combined authorities. It's not a homogenous entity. I think COVID spelt that out quite quickly, where equally deprived areas experience different COVID outcomes or outputs because the nature of deprivation was fundamentally different, whether it was inner city urban challenges or whether it was attached to rurality. So I wonder whether something that would set up the future work is to try and ascertain whether the fundamental assumption that inequality is the same or homogenous for all combined authorities is the right one to make, and if it isn't, then are there clusters that should be working together because they share a fundamental homogeneity of inequality?
Thanks, Matt. That's really helpful. And I guess this is one of the issues about this project, is that the word inequality is so broad. It encompasses so many kinds of inequality and different permutations that can take. And there could be some work we do on kind of disentangling what dimensions of inequality are best addressed at combined authority level compared to at more local level, for example. And are there different dimensions of inequality or inequality issues that specific combined authority regions can work on because of their shared challenges that may be different from other regions? That's really helpful. Thank you.
Debs.
Yeah, thanks. I was particularly interested in the point around balancing the perceived competing needs as part of pandemic recovery, because I think that's how it's framed as Greg mentioned before, often when you put health in front of things, that leads us down the way of thinking of health in a particular way. But ultimately, we're talking about, health and well-being of people, planet, and prosperity together. Just to back up the points about who's in this room and how we understand inequalities in general, and then use the data and the insight and work with communities to help frame what those issues are and solutions, and have the combined mandate to address that. So I just think it's important how we frame it as a group here, as broader than just health inequalities, which might narrow us a bit.
Yeah, and perhaps being a bit more explicit about the trade-offs that might be there in the short term in order to, realise longer term co-benefits, for example. I think being explicit about those and what we mean about when the trade-offs will occur and how they'll manifest, that's really helpful.
Yeah, absolutely. And when I was pulling together the West Midlands workshop to draw in appetite from other directorates, I was a little bit cheeky that I didn't frame it as health inequalities. I reframed it as addressing inequalities in our COVID recovery. So yeah, the power of language, it definitely makes a huge difference. So yeah.
And so I'm just going to bring in one more contribution from the chat, is from Alan Higgins. And Alan, do you want to come in and ask your question directly?
Sure, thanks very much, and really enjoyed the presentations. And the extent to which PHE was referenced as a key partner so often, which was good to hear. And I'm sitting in PHE in the Northwest and very much looking at what the successor regional public health functions will be doing on health inequalities. There's quite a bit coming down the NHS line, which is great to see, about health inequalities leadership. But I'd be interested to know about what would be expected, would be useful from the succeeding regional public health function to support combined authorities in the next few years. That would really help us, one, to get our act together on what that should be and try to shape what the mandate might be coming down from national.
Thank you. Shall I pick up from here? I think we've got, yeah, brilliant. So we've got 10 minutes left. We're going to hear from Gwen in a minute, who I think is on the call. Gwen Nightingale from the Health Foundation, just around how this project docks with a wider set of strategic work that they're doing, and why they're sponsoring it and what they're looking for it. I'll wrap up at the end around next steps. I suppose just 3 quick reflections. What we're talking about here is combined authorities that are politically led, steered through a political mandate. And at this stage, this is a project that is about supporting, I guess, the officers that are supporting into that at a very fledgling stage. So this is not about systematic or consistency necessarily at this stage between the regions. This is very much about getting the kind of support in place about how we operate and how we support, with a view to that political leadership at the regional level, and with a view to the kind of levers that we can pull. Just banking the fact that we're working with a lot of uncertainty, and we recognise that. So this is still in the shape of what is useful now, what is helpful now, what's helping us to deliver now, and not completely in the moment, but in the relative short term, with a view that if we get up and running and if it's working for people as a network, we can then build from there. And the last comment, I guess, is around this issue of the framing. Is it health inequalities? And I think what the policy team have done have tried to get that sweep of, we'd all recognise very few authorities reference the kinds of work and the kind of policies we're trying to do as health inequalities work. Even in the GLA, where there is a responsibility, we do not talk about everything in relation to the health inequalities strategy. That is just, I say, the glue that pulls the strands together. So the element of the kind of frame, I guess, is also part of the essence of it. And we would anticipate that is different in different regions. And that's part of the kind of exploration, is what's working to get the mandate and the action for that needs-based action that's appropriate to that population and that region. Yeah. So if Gwen, if you're on the call, would you like to come in now? I think you were going to give us just some quick reflections from a health foundation perspective, even, and then I'll wrap up on next steps. Gwen.
Yes, yeah, I can do. And sorry that I wasn't able to be with you at the beginning of the session. Otherwise, I would have mentioned this then. We've been funding this project as part of our Healthy Lives strategy, which has an aim of improving people's health and reducing health inequalities, but particularly through looking through the wider determinants of health. And this is kind of one of the many things that we've got going, where we're looking at cross-sector partnership working. And I think kind of this is one of the most kind of, I suppose, intellectually interesting areas for me, because it's a brand new area where there are new powers and new ways of doing things, and perhaps the opportunity to have a different set of conversations given kind of where the locus for some of the activity is. We've got particular pieces of work that's probably relevant to the piece of work around economic development. So we published a report back in September last year, and building on that, we're funding a couple of programmes looking at 4 local areas where particular activities are being implemented around economic development strategies. We've also just published the COVID impact inquiry, which if people haven't seen, they might be interested to have a look at, which looked at the pandemic's impact on health and what it might mean in the future around reducing health inequalities. And then I kind of mentioned in the chat, we've got some work going on looking at framing some of the conversations around health inequalities, and perhaps not surprisingly, some of the things that you might start off thinking are going to have the best impact and make the most impact, they don't always have the effect that we want. So that piece of work hasn't quite yet concluded and will be over the end of the year, but we're really keen to share that in the most useful way for all local areas to be able to take the learnings and adapt it in that particular space. But looking forward to continuing the conversation as your work continues, and really interested in the finding. And it's certainly, I think, an area of growth for the Health Foundation that we're interested in. What are the barriers, and how could we support kind of this different and expanded way of working as it goes forward?
Gwen, really, really helpful. Okay, so we've had a really rich conversation. I think we'd acknowledge, big ambition from officers and in each of the regions. We've worked with quite a lot of uncertainty today as well. I think we'd all acknowledge that on quite a hot day. So I think we've achieved in that context actually quite a lot, probably a lot more than I kind of thought we'd kind of cover, to be honest. In terms of next steps, 3 simple things, I guess. One is we've had comments today about the right people in the room. So I think there's something for me about kind of re-cementing with each of the regions, including the newer authorities, West Yorkshire, for example. And we may well seek your help in that. So who are the other interested colleagues in your region or in other regions that we need to be bringing into this kind of network? So David has a contact list. We're always keen to kind of cement that. So that was one action around kind of who's in the room in this conversation and shaping it. That would be helpful. Second area is we will come back to you and canvass at another level of granularity what the relatively short-term focus of this project that adds value to your work currently could be. So the mentee outcomes are really helpful in that. As sponsors, we've had some conversations about things we're grappling with. So health and wealth, and the framing of that is an immediate kind of priority, the data and the prioritisation questions, but we will come back to you and canvass a bit more on that. And then the last thing to finish on really is the offer that the policy team have made to those regions that aren't the 3 sponsors around this appreciative inquiry approach. Would that be helpful in your region? And I think the offer that you made, Grace, about, does anyone want to take the policy team up on that? There isn't boundless capacity, but as you can see, considering the team have whipped through there is huge depth and insight that they've collated through these conversations, and we'd be interested in the sponsors understanding if this is pertinent to you, and I can assure you, it will add value hopefully to what you're trying to, your endeavours at the kind of regional level as well. So I think those 3 things: getting our contact list up and running to get us in the best place, the canvassing around short-term priorities, a couple more webinars informing our conversation with the Health Foundation about how we take the project forward. And then the last thing is, in the short term, for those regions that haven't been, if you would like to pick up this appreciative inquiry process, we're making that invitation. You can follow us up on that. So what will happen after this, David? You're going to be contacting back, aren't you, to colleagues, setting out those kind of next steps. If there is anything you want to pick up in the meantime, if you want to drop me or David an email direct, always happy to hear from people. If there's any reflections you want to share, that would also be helpful, and we can pick up with the policy team in the meantime. Have I missed anything, David, just before everyone signs off?
No, that's everything. That's excellent.
Fantastic. Okay, so just say thank you again, colleagues. Hot day, lots of complexity, everyone very, very busy, carving out the time, hugely appreciated. And personally, I would really, really welcome working with the other regions, because although it may sound like London has a health and equality strategy, it is, there's a lot we could do, and we need to align ourselves to best support mayors and combined authorities to get on with it. Yeah. So look forward to working with you in the future. Have a lovely afternoon, and we'll be in touch. Take care. Bye.
Thanks, everyone. Bye.